Okay, good afternoon. Welcome to the Thurston County Board of Health meeting. It is Tuesday, October 10th, 2023. It is 4:32 p.m. My name is Ty Mentor, Chair of the Board of Health. We have all board members present other than our Vice Chair, Maria Williams, who may be zooming in here imminently. Calling the meeting to order and looking for a potential approval of the proposed agenda.
Mr. Chair, I move the approval of the agenda as published.
Second.
There's a motion and a second to approve the agenda as proposed. Any discussion on the motion? Hearing none, all in favor say aye.
Aye.
Any opposed? Motion passes, agenda is approved. Next is opportunity for the public to address the Board of Health. And I don't know if there's anyone who intends to address the Board of Health. I won't go through all the rules and parameters if there isn't. Waiting for the clerk to check the sign up. Okay, folks are here for the proclamation. Anyone online who would like to provide testimony to the Board of Health? Okay, we will move along. Next is a presentation, proclamation actually, for National Children's Health Month. And Gretchen Toller from our Public Health and Social Services Department will give us kind of a background on this.
Good afternoon, Board of Health members. My name is Gretchen Toller. I'm the Division Director for Community Wellness at Public Health and Social Services. Thank you for this proclamation and the recognition of National Children's Health Month. I would like to share a quote from Dr. Robert Block, the former president of the American Academy of Pediatrics, in which he states, "Adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. The health of our children now will influence the health of our communities later." You're likely all familiar with the study around ACEs, which is adverse childhood experiences. In this study, they identified experiences that children had before they were 18 and the impact on health later in life. With an increasing rate of child abuse and severity, an increased poverty rate, according to the census, our poverty rate between 2021 to 2022 has doubled, and the increased incidence of domestic violence, there are indicators that many of our children in our communities are struggling. The good news is that what we do to support our children and families now can have a positive impact to prevent substance use and overdose, mental health concerns, chronic diseases such as cardiac issues or cancer. I'd like to quote Commissioner Edwards, and that children are 30% of our population and 100% of our future. So what we do now really can impact some of the concerns we're seeing in our community. And I focused mostly on the emotional health of our children. I mean, there's a lot of positives with the physical health, but right now, emotionally, we're seeing a lot of struggles with kiddos. The other good news is that our community partners that we have. I'd like to introduce Dr. Joyce Gilbert. She's the Medical Director at Providence Abuse Intervention Center and sits on part of our partners group that Commissioner Mejia facilitates.
Thank you, Gretchen. That's too tall for me. Thank you for having me. Thank you for listening to me. I am Dr. Joyce Gilbert. I'm the Medical Director of our Abuse Intervention Center. We serve the 5 counties of Thurston, Mason, Lewis, Grays Harbor, and Pacific counties. And we are seeing the effects of exactly what Gretchen just talked about. I'm also a pediatric hospitalist. I take care of babies, newborns, and children at the hospital. We are right now in the best form ever for the health, the medical health of our children. Our infant mortality rate is down. Children are surviving premature births and all sorts of medical diseases, diabetes, asthma, all the things that were a struggle 50 years ago. Our children are doing well with now because of medical advances. So the medical health of our kids is phenomenal. It is the emotional health and the mental health of our children that we're struggling with. And as Gretchen stated, we now know why. We have the ACE study from 1998. We have the additional science that has proven what changes in the brain and what changes in the body when children are exposed to trauma. and our adults who currently have so much trouble with addiction and mental health issues were those children a generation ago. So the effects of that we're seeing now in the adult population. What we want to do, what our goal is to change the trajectory of those children's lives by doing trauma-informed care the right way. If we can help those children and thereby help the adults who are caring for those children with the appropriate trauma-informed care, we can change what our future looks like. And that would be my goal, and I would hope that that would be your goal for our children. Thank you so much for your time.
Questions, comments from board members before we read the proclamation? Okay, and we'll start and we'll jump down here. We have a Thurston County proclamation for National Children's Health Month. Whereas October is National Children's Health Month, which serves as an opportunity to highlight our county's ongoing work to protect children from hazards that affect their health. Go left.
And whereas we all want our children in Thurston County to thrive, and
Whereas children's health and well-being are influenced by many factors, including biological, social, and environmental, impacting their health as early as during pregnancy and continuing throughout their lifetime. And
Whereas children can become ill from environmental exposure to harmful chemicals in the air they breathe, the water they drink, or the soil they touch. Furthermore, these can be negatively impacted by social factors such as adverse interactions with caregivers, lack of socioeconomic resources, poor peer relationships, bullying, and racism. And
Whereas in fact, accidents and certain conditions originating in the perinatal period are the leading causes of death for children in Thurston County between 2019 and 2021. And
Whereas healthy communities and families are fundamental to children's well-being and have a profound influence on their health outcomes, resiliency, and access to resources for their health and safety needs. And
Whereas strengthening the economic support for families, promoting social norms that protect against violence and adversity, and ensuring a strong start to life are critical for the health and well-being of children. And
whereas local home visiting programs like Thurston County Nurses Family Partnership, Family Intervention Nurse Program, and many other community programs are working in unison to support the needs of children and families in the community as it relates to supporting early and consistent prenatal care, promoting positive caregiver-child attachments, increasing home safety, and improved childhood development and well-being.
now therefore be it resolved, the Board of Health hereby proclaims October as National Children's Health Month in Thurston County and encourages all community members to improve environmental health, economic support, and overall well-being of our children and their futures. Adopted this 10th day of October, 2023, your Board of Health.
photo?
Robin, let's go.
Pulling me into these.
Thank you. All right, thank you so much. The Board of County Commissioners also declared Breast Cancer Awareness Month just a few minutes earlier, which also relates to public health, of course. That's why we have our pink ribbons on. So very good. Next up is item 3B, which is a presentation regarding Victims of Mass Violence Response Plan Project presentation. And who am I looking toward for this?
I would go to Jen.
That will be me. Thank you, members of the Board of Health. Thank you for having us. I'm Dr. Jen Freiheit, and I'm at home nursing a cold and a sore throat, so apologies that I'm not there in person, but I thought I'd keep my germs here at home. So just to introduce this today, Thurston County Public Health and Social Services, in cooperation with Emergency Management and the Prosecuting Attorney's Office, came together in the fall of 2022 to receive technical assistance from the Office of Victims of Crime Training and Technical Assistance Program to produce a Victims of Mass Violence Response Plan. As Commissioners Menser and Edwards may recall, back at the Board of Health on February 11th, 2020, you had heard background on how the Thurston County Family Assistance Center plan came to be. And this Victims of Mass Violence Response Project will build upon that Family Assistance Center and is a continuation of the work previously done for that Family Assistance Center plan. Since that time, we have collaborated with community partners and government agencies, which include federal, state, and local partners, to convene stakeholders meetings to work through the 16 best practices of the mass violence planning process. So we are very fortunate today to be in the past as well, and in the future to be working with Dr. Krista Flanagan, who will share with you many more details of the program and the planning process. Thank you.
Great. Thank you so much, Jen. This is Krista Flanagan, and thank you, Board of Health. It's an honor to be here today. And so as was stated, I'm going to be sharing with you just kind of a brief overview of a plan, the discussion about a plan to respond to victims of mass violence incidents should one occur in your community. And unfortunately, it's critical that you have such a plan, because that, I hate to say this, but really it's a matter of, it's not really a matter of if, but when we see these kinds of numbers. Human caused and natural disasters and emergencies happen everywhere, and we're seeing that, of course, across our country. And we have learned that effective response depends really on effective planning. That's the one mitigating factor that we have seen in every incident, that have a plan that would have really helped mitigate some of the issues that arise. And mass violence incidents themselves are complicated because they often involve large numbers of living victims of crime who've been impacted, as well as family members of the deceased. And the numbers of those people are often unknown, and the identities might be unknown due to leaving the scene of the incident quickly to keep themselves safe. And therefore, gathering information and connecting people to their loved ones can really be very challenging and take some time. Mass violence incidents are criminal incidents, so therefore they involve law enforcement investigation, interviews of witnesses, access to victims' assistance and crime victim compensation, and high levels of coordination are needed to process and account for all of those who were impacted. And it's important to note that a victim response plan is not intended to replace your existing emergency response plans, but really to enhance and support what you already have in place, but with the focus being on the needs of victims and the community as a whole. So a comprehensive plan requires collaboration among multiple disciplines, both your traditional and non-traditional partners, and no contribution is too small or insignificant. And it also really requires respecting the needs of every entity in the collaboration. And as I said before, above all, it needs to be victim focused. It's not about the agencies. Many communities have mass fatality annexes, and that's in addition to your all hazards emergency response plan. And the plan serves communities when there is an incident involving more dead bodies or body parts that can be located or identified and processed for final disposition by all of the available resources. There are often shortfalls in this type of plan in dealing with injured survivors and their loved ones, or legally defined victims of mass violence or terrorism. So the CDC, this might look familiar to you, as the CDC and other health-related agencies advise jurisdictions to have a plan to manage human remains, after a mass fatality incident. This plan is often an annex to your all hazards plan and requires collaboration. And this plan focuses on fatalities to support families of the deceased. And protocols are in place that dictate how the remains are going to be identified and handled. So you can see it's management operation, fatality management, personal effects, etc. Now, mass violence response annex has a much broader focus than a mass fatality plan, as you can see here. The response annex adds the management of living victims and their families to the management of the remains. So this shows you the different components of a mass violence response annex. So it's looking at how to find for living individuals to find one another. It looks at maybe the number of notifications, not just death notifications, but injured, as well as the missing and also those that are present and not injured. So it expands on the notification teams. It also looks at locations to access services to meet those immediate needs, looks at crisis communication that should be coordinated in a trauma-informed way. It has to be effective in managing local, national, and sometimes international platforms, depending on the type of incident. I mean, we look at the Las Vegas shooting that happened, that, we were dealing with victims all over the world that had come to Las Vegas to attend this conference. So the needs of the victims and loved ones in the community continue for an extended period of time. So it's beyond, this plan is not looking at just the immediate phase. It's looking at the longer term phases as well. The longer term support. It's looking at managing donations for both the short and long term. It's service donations as well as financial donations, looking at how to deploy volunteers, a lot of that are unsolicited, as well as those that we hope that are trained and affiliated. It's also looking at, this plan includes also managing memorials, vigils, dignitary visits, and looking at that required coordination, and also the resources and emotional sensitivity that are needed to manage all of this. And finally, the plan also addresses looking at funding that can be needed to help assist in the longer term resiliency for an under-resourced community in the event that one of these incidents should occur. So a well-coordinated response is what is needed. And so what we have to acknowledge is that a comprehensive plan is beyond assisting the victims, as I said, in the acute phase. We have to be looking at the long term. I always say that this is a marathon, it's not a sprint. So I'd like to talk a little bit about why a long-term response plan is necessary. I have been responding to incidents of mass violence since the Oklahoma City bombing, and have responded to a number of more incidents than I care to acknowledge, either as a boots on the ground responder, victim advocate, or helping communities in the immediate aftermath to establish family assistance centers and long-term resiliency, and then working with communities now in helping establish plans. And while what I will tell you is that every incident is unique, because it's, every population that's impacted is unique. The resources that are available are unique. The dynamics of the community, culture, et cetera, are unique. However, there are also lessons learned from other communities where we can say that there are some things that the communities have in common that they will experience. How they manifest is what is unique based on the community. So I call them established factors. So we know when we're talking about mass violence, we're looking at multiple victims. Well, why is that important? Well, it's important because even though that all of these victims share an incident does not mean that they have the same experience with the trauma. So it's making sure that there are resources in place to deal with the vast array of responses to trauma. And it's also recognizing that there is going to be multiple agency response, your traditional responders, but also, as I mentioned before, your non-traditional responders, and looking at multiple jurisdictions, because your normal agency resources are going to be overwhelmed. And as a result of that too, that we're looking at the vicarious trauma for responders. And this impacts those that aren't used to working with victims on the daily basis, but also those that are. So your traditional responders, because all of a sudden now, you know, they're trained to deal with certain types of events on a regular basis. But even though it's hard to be trained to be emotionally prepared to deal with these types of incidents, especially when you're looking at a small community where it's likely that responders are going to know those that have been impacted by the incident and they themselves might be impacted. It's also true that these types of incidents, there's a political atmosphere that is that just happens, and a lot of this has to do with the fact that politicians are called called to the table to be accountable. It's like, how did you let this happen in the community? What are you going to make sure that this doesn't happen again? And what are you going to do for us now that it has? And then also too, with politicians, that because this isn't something that they deal with on a daily basis, they don't know what the resources are that are available. So part of a plan is to make sure that they are informed so that they don't overpromise and know what resources are available and what they can expect in a trauma-informed way. And then looking at copycat incidents and conspiracy theories, what that does, why that's important, is because it exacerbates trauma and prolongs the psychological impact of trauma that we might not see in a natural disaster. And a lot of this has to do with, you know, this intense media coverage. Whenever there's an incident of mass violence, that there's going to be media coverage. Now, because there are so many of these now, that we don't see the longevity of coverage unless we see something like a Robb Elementary that we saw in Uvalde, or a Sandy Hook Elementary that we saw in Newtown, Connecticut, where you're seeing young children, or if you're seeing really significantly large numbers of victims. But your local media is certainly going to be covering these types of incidents on a longer term basis. We've also been seeing in the last 5 years or so consistent activism and also lawsuits that wherever, you know, whatever the venue is that these incidents take place, is that you're going to see that people are going to be sued, that agency is going to be sued. And it's one of those, again, those established factors, and it's preparing the community for that. Because here's what happens is, because people, when the lawsuits happen, is that people will shut down and they'll stop communicating and collaborating. And that's not helpful to the victims. And so working with communities in your planning to recognize that this is an established factor. And so how can you still serve victims and not jeopardize, you know, the status of what, you know, not protect yourself from what may happen with a lawsuit. We also know that communities are impacted and there's vicarious trauma. And so they need to be tended to as well, and having a plan that includes that as well. And so this plan addresses those established factors and looks at the phases of response. So, you know, we always like to say we need to have a community that plans first, but then you want to be planning for that acute phase. And so this is during the incident, the immediate aftermath, the completion of the rescue. Then you go to the intermediate and transitional, the longer term as well. And then each of these has a victim-focused component in each of these phases. And then finally, you were looking at planning again. So even when you establish your plan, if you have an incident, you need to go back and revisit that plan and say, hey, what worked and what was effective and what could we have done better? We can go to the next slide, please. So now you have all this information. Now what do you do? Now what? So what has been happening in your community, and it's really been remarkable, and I'm working with several communities in establishing plans, is that, you know, while you're not in the midst of a crisis, now is the time to plan and be forging those relationships. And what we have been doing is looking at these 16 best practices and going through each of them, and we have an annex template and looking at the plans that you already have in place and how can we enhance those to make sure that they are victim focused. And then some of these are new that might not be in existence yet, but what I have been seeing with your community has been some great communication and the involvement of emergency management and the expansion of what they are doing, as far as, because that's what emergency management does, right? Is brings people together and does planning. And so finding their place in this emergency, in adding to their emergency response plan and bringing in the other parties. And that's what we've been working on this last year, are these best practices and how to, again, look at what it is that you already have in existence and then making it victim focused. And the 16 best practices we have based on a toolkit that, the next slide, please, that Office of Victims of Crime put together from what we did in 2013. At that time was we brought together, we held sort of discussion groups all over the country and said, what are the lessons learned? What would you say that a community needs? And you can access this. It's there's checklists that are in there related to planning, which we're kind of going through with these 16 best practices that was created from, but also a checklist for recovery as well as response. So those are resources for your community if you should ever need that. So that's kind of an overview of, very, very brief overview of looking at mass violence response. This is my contact information, and it's really has been and will continue to be an honor to work with your community and all of the different agencies that are involved, because as you can see, this is a very comprehensive plan. But that's what we have learned is really needed, because we are looking at the long term, because most of the time communities are planning for that acute phase. But what happens once the bodies are taken to the morgue and to the hospital? I know that sounds a little harsh and brash, but that's the reality. That's what communities plan for, but it's what happens after that I think that communities are lacking, but your community is really working to change. So thank you for your time. And if you have any questions, please ask them.
Okay. Board Member Vasquez.
So many questions.
Yes.
Thank you for the presentation, Krista. This is really helpful. To be clear, we don't currently have a plan in place, but it sounds like we're beginning to pull together the components of a plan within Thurston County.
Yeah, you have an emergency response plan, and there's a mass fatality plan like we talked about. It's just looking at where and there's a communications plan. There are some notification pieces, but how can you expand upon that to incorporate the best practices?
And the specific component of a response for victims of mass
Yes.
violence, that's the
We're
additional.
looking at, yes, for victims of mass violence, looking at both the immediate phase. And so when we talked about those phases, there are different components. So, the Information Notification Center, Family Assistance Center, Community Resiliency Center, and then if there is a live suspect, then also making sure that victims' needs are met during the prosecution and sentencing.
And maybe a follow-up question. As a politician,
Mhm.
what would you recommend to this board? Many of us are elected officials.
Mhm.
How can we be most useful other than having a plan?
Yes, I'm so glad you asked that. And so what we recommend really is knowing what the plan is and being open to discussions and maybe some training or conversation about what the resources are in your community related to serving victims and what it would look like, how this plan would roll out and what it is. And maybe even, I strongly recommend sort of having a trauma-informed care 101 training about here's what we know that victims need, that victims of crime need, but certainly victims of mass violence need, because one of the things I will say that I've seen this in every community that I've worked in is that the politicians, that you all are very well intended. You want to serve your community. You're in shock. And so it's kind of like you sort of want to offer the moon, but the moon's not available, and might not be what's needed. And so to have conversations about what is it that victims need and how to relay that information, because in your messaging to your community in the immediate aftermath, it needs to be trauma informed. And to be letting folks know that, it's normal for you to be experiencing this, and here is where you go to get help.
Thank you.
Mm-hmm.
Nope. I'm making a list of acronyms and I'm trying to fill it out, and I got a couple of them while you were speaking, but starting from the very first page, what is ICP-TTA?
Okay, that's improving community preparedness for incidents of mass violence and terrorism.
Okay. And this OVC, Office for Victims of Crime, is that
Yes.
federal government thing or a state
Yes.
government? Okay,
Yes, thank you. So Office of Victims of Crime is out of the Department of Justice. So any of your victim programs that are in your community, most likely they are receiving money from Office of Victims of Crime through your state VOCA, which is your Victims of Crime Act. And those are grant funds that come through the feds that go to the state through a grant process. And that's, provides, funds your, maybe your district attorney, your prosecuting office, victim advocates, your rape crisis centers, domestic violence programs, they receive VOCA dollars. And Office for Victims of Crime, because that's what they do, what they recognize is after these incidents that communities, their resources are overwhelmed. So, when people are doing their budgets, you plan based on the victims that you're serving this year. You can't plan for an incident of mass violence related to numbers. And so that, you're often additional staffing is going to be needed. If you need to establish a resiliency center, that has to be staffed. So the Office of Victims of Crime has set aside funds to help support that. And that's one of the things that I also do is work with communities in the aftermath to access those dollars.
and then I saw FAC and I see on a different page, it says Family and Survivor Assistance Center. Can you explain what that
Right.
means?
Sure. So FAC is a Family Assistance Center or a Family and Survivors Assistance Center. They're one and the same, essentially. And so after in the acute phase, we have what's called an Information and Notification Center or an INC that's established, that's open for about 24 hours. And that is where, because when something happens somewhere, it goes out on the media, loved ones are going to be flooding the scene. And so there needs to be a place where they can go to get information, where they can be safe, where they are not impeding the rescue and recovery efforts. So that would be the Information Notification Center or INC. After about the first 24 hours, 48 hours, an FAC or Family Assistance or Family and Survivors Assistance Center is open. And that is a location where resources are all under one roof. So people don't have to go from agency to agency to agency. So you might have, you would have crime victim comp, maybe some behavioral health. You would have services that are specific to the population that has been impacted. There might be funeral homes, there might be travel arrangements. Red Cross is usually there. If there are church groups that are offering maybe some resources, might be some emergency funding, etc. So it's all under one roof. And then they have navigators that help walk them through and assist them to go from table to table to make sure that they're getting all of the resources that they might need. And a Family Assistance Center and FAC is open usually no more than 10 days, but it depends on the size and scope of the incident. And then that will then transition into a CRC or a Community Resiliency Center, which is looking at longer term needs that's focused on those that have been impacted by the incident. And that can be open for several years.
And that structure you just described, is that a best practice?
Yes.
So we may
Yes.
not have that, but it's recommended that we plan to have something like that.
Yes.
Okay.
Yes. Yes.
Yep, go back to Board Member Vasquez.
Have you seen in instances where communities have done this well or needed to have this response, do CERT trained folks participate or help out? The community emergency response teams, do they respond in supporting victims of mass violence? I know usually CERT doesn't respond to terrorism.
Mm-hmm.
What I'm talking about here is sort of the aftermath where victim support is important.
Right. And I have seen in some communities, yes. And so part of this planning process that we've been doing is identifying areas where training is needed. So your CERT, or you're even looking at maybe your domestic violence programs, that they deal with domestic violence victims, but they know how to work with crime victims. So what it is just expanding upon their training about, okay, let's talk about mass violence and what you would do in working with mass violence, so that you have a larger pool of folks to call on to to provide the appropriate intervention and support. And the same thing related to death notifications, because, you know, the way that it might be set up is that if your medical examiner is doing those, you know, in conjunction with law enforcement, is there, you know, you might be looking at multiple you know, death notifications, maybe in the double, or hopefully not, but maybe triple digits. And so how can that be done in a way that is that's trauma informed? And so getting people trained on the front end, but also being prepared to do what we call just-in-time training that would be available, you know, at the different centers that I just identified.
Okay, well, we'd really like to thank you, Ms. Flanagan, for your presentation.
Absolutely. Thank you so much. And if you have further questions, you have my contact information, or you can reach out to Sherry, participate on these committees. And I just want to thank you for your time and for the opportunity to work with your community.
All right, thank you. Jen, anything else before we move to the next item?
No, thank you very much.
Okay, very good. Next up is item 4A, Fiscal Subcommittee Update. And I'm going to turn to Director David Bain from PHSS to kind of frame this for us and kind of walk us through what we need to know.
Yeah, thanks. We have spent the last, I think 4 months or so working with the fiscal subcommittee, and really spending a lot of energy trying to get the subcommittee up to speed on the nature of the department, our fund sources, our org chart, and then moving into what our needs are going forward. As Robin has mentioned a couple times to the board, that this is the beginning of a process, not the end of one. This is the first time that we've had a fiscal subcommittee. It's the first time they've been involved with our budget. And so this is really an introduction into how we operate, and it gives us a framework for how we want the board to engage with the department moving forward. So today, I'm going to go through very briefly an overview of the department's approach to the budget, and then I will turn it over to the subcommittees to get their sort of reaction and response to that approach. And then they will present, if you will, to you all about their take on that and whether they think our approach is in the right direction or if they have suggestions about how we should tweak that going forward. In the future, I can imagine a much more robust process with the subcommittee. We would start the process far earlier and get a lot more community input, things like that. We were squished a little bit on the time front with this one. We did the best we could with it. So I think what you'll hear from both myself and from the subcommittee is, again, kind of a high level overview versus maybe a real in-depth line by line approach, if that makes sense to the board. Robin, anything you just want to add to that?
I think you're right on track, David.
So I'll kind of paint the picture overall for the department. Thurston isn't unique in the situation it found itself in from public health. Really for the last decade, 2 decades, public health departments across the country and across the state, aside from places like King County and Pierce County, who have additional sources of revenue, have struggled to maintain their sort of core functions. We were no exception to that. One of the, I'd say one of the biggest legislative successes in Washington State and the country, I would argue, was the passage of the Foundational Public Health Services funding stream, which started about 3 years ago. And the purpose of that funding stream was to make sure that regardless of what zip code you're in, what county you're in, that you could have a core amount of funding that can enable you to do your core services. I bring that up because probably the significant part of our budget request this year is really our allocation of that funding. So I'm painting the picture for you about FHS because that is our budget going forward. The other fund source that we're really relying on, or 2 other fund sources we're relying on, are the TST fund source, and then we've got some existing funds through the state related to our communicable disease program. But those are really the 3 major fund sources. There's not a lot of other options that we're using. So I wanted to make sure the board has a reminder that FHS was created to really fund and bring departments up to a kind of core level of services. And I will tell you that we're not there yet as a state or as a county. The committee which sort of oversees FHS envisioned a 10-year process of sort of getting the state to chip in enough money to where they thought the system would be fully funded. We're about halfway through that process. And so I would argue that as the county, we're also in the early stages of that process as well. One of the things that I've done since I've started here was to really assess our capacity, our capabilities as a department across each of our major divisions. And I will say that there's several areas where sort of gaps really jumped out at me. And so what we've got on the screen is an org chart of the department. And what we did is we coded where we are asking for new positions or looking at reclasses for positions. And so I'm gonna walk through this fairly quickly. And if you've got questions, please interrupt me, but I wanna kind of move fairly quickly. So on the slides, the first slide you're gonna see there is our overall org chart, so you can go down from that one. And the next slide will be our kind of first division or office, which is our administrative services budget. I'm gonna pause here for a second and maybe do even more reframing. What you'll notice about our budget is a couple of key kind of themes that have happened here. I asked our team to put in requests that will support our mandated services, requests that will support our administrative capacity, and requests that will support our sort of management capabilities. And so you'll notice a theme for our requests. These aren't requests that are sort of nice to have extras for us. These are pieces that either been missing or pieces that the state is saying you need to have to be up to speed. So administrative services, the really quick highlight I'll give you for these, within this group, there's a couple of functions. You've got on the left column there, you've got really our kind of traditional administrative services team there. We're looking at an additional person there. You've got our EPR, emergency preparedness group, is over here. We're looking for a position there. And then we also have our public information work and a brand new position of looking at a Board of Health a clerk who can support this work. As a high level for each of these positions, I just want to note what we did is we went through and either looked at where did we have holes. So the office assistant, for example, was a place we had holes. Or where was it that the state was providing funding that said, okay, we're giving you funding to do X, Y, and Z. And so for the EPR program, for example, we got funding from FPHS specifically to do this work and have a position to help in this work. Similar with the public information side, their state specifically said, here's funding to go towards communication efforts and positions. And so we're sort of following that lead there. Let's keep going, because I don't want to spend time again through each of the org charts. I want kind of a high level view of this.
One other thing though,
go ahead.
just the color coding on this chart.
Sorry, yes,
Items
Robin.
in blue are positions that we already have. Items in orange are positions we have, but we're requesting a reclass. And items in yellow are new positions being proposed by the department.
Thank you. It's a good reflection there. When I walk with you through this budget request to the Board of Commissioners on Friday, I will go in depth through each of these divisions and each of their offices and describe what they do. Today, I'm trying to keep it a little high level, but know that you'll get a more in-depth conversation about each of the functions and what we're doing to support them.
You'll also note on the page, there's the maintenance level budget and then the total amount of the policy level request. So again, very high level, but it's a demonstration of where we're filling in the gaps in the foundation of foundational public health.
Thanks, Robin. The next slide we'll go quickly. It's our fiscal section. We're looking for one position there to really help with our procurements and contracts work. Again, this is core work for us. We're a department that has almost literally 100 different contracts that we have to manage on at any given time. And we have not had dedicated support to that work. The board knows we've had audits, we've had inquiries into how we're able to do this work. This was a significant need for us. And the state also included funding in FPHS this year to support our fiscal office. So it's actually in the fiscal request there. Okay, moving on to some of our more programmatic areas. The next slide you're gonna see there is our community wellness budget. You actually heard from Gretchen a little bit earlier with the proclamation. This is this division. The majority of the funding that's being requested for these positions here is coming from the TST program. There's also some other funds that we're looking at as well from existing federal funds and FPHS funds to support this work. The picture I want to paint here for the community wellness budget is at least twofold. One is that we have had an incredibly significant backlog of cases over the last several years, but it's really seen a giant increase over the last 2 years or so. And we know that our current staffing is not able to meet that backlog. And so we're looking for additional nurses and positions to support that. But the work isn't just done at a clinical level. Those folks also need administrative support. They need supervision. So when we're looking at adding nurses, it's not just, oh, you add one person, you resolve the problem. You need a team that can support that work. And so that's what you're gonna see reflected here. I also want to note too, one of the things that's so stark to me when I came into this role and I looked at our org charts, I want you to imagine this org chart and you take away the yellow boxes at the top of this. This represents two levels here. It represents a level of management that does not exist currently in the department, and it represents administrative support that does not exist currently in the department. So right now, in our current state, right now, you've got a division director with none of that support in the middle. So that means that person is responsible for the boxes below them. All of those boxes, they're ultimately working through that. And so something I just want to sort of visualize for folks as we move forward. The other thing I want to note quickly is that we're looking at some community health workers and social workers. There's many reasons behind that. But one of them I will note was that the kind of cases that we are seeing in this county, you're seeing a lot more acuity in the kinds of both in kids and in parents. This is something that we want to be better equipped to handle and to work with. Next is our environmental health budget. And so next slide there.
Maybe
Oh, sorry, go ahead,
just a
Robin.
quick question.
Yeah.
How many positions does the program currently have? I just counted all the yellow boxes and the orange boxes, but I didn't want to go through all the blue boxes if you just knew that.
Yeah, I don't know offhand. Gretchen, do you have a number at the top of your head? By any chance?
I mean, the whole program, the
Or
public
community
health,
wellness?
the entire public health,
Oh, for our whole
the whole
department.
org chart, this whole thing.
We have 145 people currently.
Okay.
Which is about on par for kind of a mid-sized county health department. So if you look at us, compare us to say Kitsap or Whatcom County, we're on that range. And if you move up to a county like Pierce, they're about 3 times our size in terms of the number of staff they have. And then King County, I think actually at one point had more staff than the state had. Which is kind of a fun fact. Good, but thank you, good question. So that next slide is environmental health, which is our largest division in terms of staffing. Again, given the geography and population of our county, that makes sense. Their structure, again, what they're looking for is support in their management as well. I think the same exercise I went through with the last slide, I want to do it here. There's that yellow box at the top here. It's an environmental health program manager. So if you remove that box, you will look at our current state, which means our environmental health director, that position is supporting not just the 2 other managers, that middle column is reporting directly to that director. So that person is not only leading the environmental health division, they're also managing an entire section by themselves. The state is providing funding for EH specifically to increase support for management, and that's what that position represents. Next slide. This is our disease control and prevention section. This one is a little bit unique because most of the boxes you see there, the yellow boxes in the middle, are actually current project positions. So these are not positions that are brand new to the department. This is really where our COVID team has been for the last 3 years or so. At the peak, you had I believe over 100 or 120 FTEs that the department had to hire to support the COVID efforts. We're down to about 20 people for that. This represents a section of that we believe is sort of core, not just for COVID work moving forward, but also for other outbreak and communicable disease work. Again, one of the things when I got hired that I noted really quickly in this sort of org chart was the fact that for a county, for 300,000 people, you had a handful of epidemiologists, a handful of nurses, and that was about it. And this is an item that I know historically has been kind of flagged in the past, and I will also kind of wave the flag as well to say, for a county our size, for the kind of populations that we're seeing grow, we wanna make sure that we are ready to respond, not just to outbreaks like COVID, which happen, people say once in a lifetime. There are plenty of other infectious diseases that happen on a regular basis that this department, to be completely blunt with you, is using sort of duct tape and glue to manage and to get by. And so this request is to look at our team and to have them be authorized to, not just to extend temporarily, but to be permanent parts of the department and do work beyond just COVID, but work that extends to all of our various communicable diseases, and to have support not just for diseases, but also for immunization, for social workers that help support folks in need, and then increased epidemiological capacity. One of the things that I mentioned to the board, I think a while ago, and I'll bring up again, when I think about my priorities for this department moving forward, I actually cannot with certainty give you a great list of priorities because I don't have confidence in our ability to do assessment. We don't have enough resources and staff to do an in-depth assessment of what our needs are. And so for me to be able to bring before the Board of Health, Board of Commissioners, planning and ideas for the future, I have to be able to have confidence in the data that we have. And so the request here is you're seeing not just folks who are supporting our outbreak work, our immunization work, but also epidemiologists who will help do our assessment work going forward too.
Can you explain to the board, it's just sort of what's the difference between on that org chart, you have epidemiology on
Yes,
two sides?
Thank you. And so what you're seeing here is an epidemiologist on one side that is really working with our clinical program, so working on looking at HIV, looking at hepatitis, looking at sort of the work there in surveillance. On the other side, on the far right, that epidemiologist will focus on environmental health. So this department has never had an environmental health epidemiologist. So when we have things like foodborne illnesses or vector-based diseases, think like West Nile, for example, which is mosquito-borne, we've not actually had an epidemiologist who could focus on that kind of work. And so a lot of the work that we've done in the past, we've outsourced to DOH to help support us because we haven't had the people or the staff to do that kind of work. So that's the difference between those two EPIs.
Oh, wait.
Okay,
Okay?
yep, keep going, you're good.
Right, I just saw the excitement from the commissioner over there. I didn't know if she wanted to say anything. All right. Social
Got me all
services.
day next Thursday, so. Oh, wait.
Take notes. This next slide is our social services area, excuse me, social services area, can't talk, which encompasses a couple of programs, our veteran services, our DD work, our special rec program. We are not looking to add to that particular budget, but of course we want to make sure you see what it looks like, so you have some context there. Next slide. This is our housing office. They're looking at just a couple of positions, actually one position that would be new and one that'd be reclassed. We're really looking at someone who could help us with our rental assistance work. This has been a really high need area for the county, and it's something that we feel like it should be a high priority for us moving forward. And again, we have funding that is very specific to this kind of work that we can use for that position.
So when you, just real quick, when you show us the reclasses,
Yeah.
what's in the box and where it lands is what you're reclassing it to?
Correct.
So you'll tell us where it's coming from,
That's a good, yes.
just so I'm clear.
Yes, this one, just as a quick side note, I'm not gonna weeds. This one is already a social service program specialist one, but it's really, we're moving it from being a half-time to a full-time. So that one's a little bit more of a weird one. But generally speaking, the orange boxes, you're seeing the final request versus the original. And it will walk through it on Friday about where they started and where they wanna be at the end of the day.
It's 5 minutes, right?
And then finally, the last slide is TST, which is a program that many of you are familiar with. It's a small but mighty program. We've got two things here. It's actually, it's not, this one's missing the color, but we're also looking at a reclass for that program manager, to go from a program manager to a senior program manager because the scope of the work that they're doing we think is more appropriate for that class. I will stop for a second. That was kind of a wild ride there through each of those division slides. But I want to once again kind of take us back up to a high level to remind this group that the work that we did with the fiscal subcommittee was to really talk at a high level about where the biggest gaps were, and where we needed to sort of put our attention and funding. Some of that was dictated by the funding we got, right? There's no getting around the fact that the state said, okay, for your foundational public health money this year, here's 5 or 6 categories or buckets you need to work through. I was excited about that because those buckets lined up with needs we already had. It wasn't magic. They knew that most counties are suffering and dealing with what we're dealing with. We're really sort of hopeful that the state will continue to sort of support us moving forward and continue to increase our funding levels. But if we got no other funding going forward, this funding and the funding that we got from the last couple of years, I think really provides the department with an actual foundation to to move forward. Instead of us feeling like we were always sort of chasing our tail and having to get temporary workers and having to outsource to the state and hope for the best. I will note for you guys as one example of why I don't want to continue to rely on the state in terms of their staffing. They've told us directly that there's a point in time where we can't continue to rely on them to help us with communicable disease without us paying for it. So in the past, when we've had outbreak issues or we've needed epidemiological support, we've been able to come to them and support us. They've said, we care about you guys, we love you guys, but you're getting funding from us actually to do this work. And so if you're not gonna use that funding, at the very least, we're gonna have you pay our staff's time to do this work going forward. And so one of the things I wanna just note for us is that the work will get done. We're a department that has been resilient, and I'm incredibly proud of what we've done with the current budget, of the current staffing. But I think one of the things that I need to be sort of honest about is where we need to be able to be going forward, and we can't get there without our foundation being covered. And so I will stop talking now, and I will sort of give it over to Lynn and Dr. Harvey, sort of for their sort of sense of what we've talked about, their kind of acclamation of, are we heading in the right direction with the kind of areas I'm trying to target here, and any questions that the board might have going forward. So I'll end there.
Board Member Mejia, before we jump to the subcommittee members.
Yes.
I do have one question.
Yeah, please.
Thank you for the organizational chart, and I'm wondering if there's alternate recommendations. Since I know that this money has to be spent down, is there gonna be alternate recommendations to the board just in case there's maybe a different direction or something different that can?
It would depend on the funding source. So for some of these, I'm trying to find an example off the top of my head. So with EH, there's funding that came in this year that's specific to supporting EH leadership, EH management. I think that the flexibility you would have as a county would be, do you want to support us doing an EH program manager or a different kind of manager? We couldn't use that money to support a nurse manager, if that makes sense. So you'd be kind of limited with that category. Or the funding for communications, for example. It's intended to support position and resources for communications. So yes, for public health, that makes sense. There's ways we could sort of, maybe we think that the classification we're looking for isn't appropriate. That's something we definitely could have wiggle room on. But I would say for the FHS funding, we really do have some limits to sort of how far we stretch those dollars. There is of course room for us to look at some of our existing funding, but for the request that I have, most of this is pretty tied to what the state is saying we can and can't do with it. With TST funding, obviously that's funding that you guys are familiar with. There is plenty of room for you all to look at that funding and see where you want to go with that. But I would say on the FHS side, we're pretty prescribed, but I'm happy to work with the board to think about where we can be creative and how we can kind of assess that funding.
Can I do a follow-up to this?
Yeah.
My follow-up is, I know that as all these positions are laid out and knowing how the market has been in the past where some positions have been difficult to hire for, and knowing that there's timing
Yes.
that goes with this, I guess I'm wondering, right, with those vacancy savings, is there also an alternate to that as it comes along? I guess,
Yeah.
as a Board of Health, right, we do not want to see, and I know also as a Board of County Commissioners, we don't want to see that, any of that funding going back and our
Yeah.
community losing out on those opportunities.
Yeah, I actually really appreciate that. I think that's something that would be a good discussion to have. I know that internally that we've looked through and tried to have at least an initial plan of action about timing of when we'd hire certain positions. And the priority for their hiring is based on the priority of the funding, knowing that for the FPHS funds, for example, we have to get that money spent by, June 30th of next year. Those positions would be higher on our list of when we want to hire versus a funding that is a little bit more flexible. So things like that we're looking at, but I absolutely think that it'd be critical. I think I of course have my own thoughts and ideas about some contingency funds, but I think that it'd be really important discussion for the Board of Commissioners to think about, okay, if we do end up with, like you said, sort of vacancy savings based on the timing of these positions, it would be good to think about what do we do with that funding and how do we think through that. I agree. I will tell you though, I've been pushing my team to do our best so that if something were to happen, we can't hire, it's because of the market, not because of us, right? I wanna make sure that we're ready for what's coming. And if we struggle, it'll be because we're struggling with the candidate, not because we struggle to hire. But yeah, I agree.
I'm also wondering, is this also maybe a good practice for the financial subcommittee too, right? Like as a brainstorming session with staff and just using, those tools in the community, right? Like Board of Health members who are out there in the community and just being like, well, is there a possibility maybe with this funding, knowing that it has to be from a specific bucket, that maybe we could do this and that could be, I'm just
Yeah, I know,
throwing
I
it
really
out there.
like that, and I think it's something that I would love to sort of see us grow into is that idea of connecting with sort of community leaders, community folks, and get that sense of where we can spend funding if we're in a pinch and we can't do what we originally thought we were gonna do. That would be really useful moving forward. The other thing, oh yeah, so basically at a high level to answer your question, yes, there's some room for some of the fund sources. For FPHS, you've got a little less room in terms of how far you can go with it, but it's still, obviously, we're putting together our best sort of attempt at what we think the position should look like. And obviously you guys have as the Board of Commissioners, have the ability to go, you know what, we think that this is a better position for this. Where you spend it, we've got more constraints, but how we look at it within it, we definitely have plenty of room to cover conversation.
Can I assume, David, that the proposals you have made is an expenditure of all of the foundational public, not more and not less than the amount of foundational public health?
I have to pull up my magical spreadsheet, but I believe that we got it down to like a few $1,000s basically, in terms of what we were looking at. Again, that's
Is that about $4 million in new money?
No, so you're saying the total amount. Let's see, it would be
No, in new money.
New meaning,
New money would be a
new
million.
before this whole thing started a
Yeah.
couple years ago?
Yeah, I mean, continued fund, and we
Yeah,
have
so if you took our
continued
base
funding-
amount plus the
funding.
new amount, I think we'd be at like almost 4 million, yeah, like 3.9, I think, or
Yeah.
3.8, correct, yeah.
Okay, turning to our intrepid subcommittee volunteers.
Sure. So I will say, first of all, it was a steep learning curve, and many thanks to Director Bain and to Robin as well for your help in like starting from point A and getting us to where we are. I really appreciate that. I think our committee in general, and I'm speaking a little bit for Maria too, who's not here, appreciate the focus on the capacity building, doing a really good job of identifying the gaps and building capacity so that you can then go forward and look at new programming or expanded programming to meet the community needs after you get to that capacity building part. Because of my work in schools, I'm very aware of the maternal child health and nurse family practice needs, as well as the environmental health needs, and the leadership in those two departments is really important. So I think overall, the other thing I would say is there's a lot of discussion in our subcommittee about behavioral health needs in this community, from birth to cradle to grave, really. And we hope that's a direction we'll look at more in the future. And I know that that's on everybody's radar. So do you have anything to add to that? I think we just in general support the asks here and really look forward to seeing a full staff to do the work that is out there.
Thank you.
Yeah, and I think I of course definitely appreciate the kind of hand-holding, trying to get the baseline knowledge, and I'm sure next year will be more helpful too as well. But I think these are all very appropriate asks. I think we lost a lot, like over those 10 to 20 years where you're like just as a person who's been here that long, you can see the things that we used to have that were sort of proactive and preventive that we don't even have the expertise here anymore. So I'm really looking forward to having that kind of built in there, like the outbreak investigation kind of shifting from like COVID response to be able to go back and like, okay, let's look at our schools, outbreak prevention, hospitals, restaurants, all of that, daycares, like all of that stuff, being able to do that. So they're both ready to respond, but also potentially prevent. And then obviously, that backlog of patients that could be needing a nurse family partnership nurse, I think is really important to staff that as soon as we can, partly because in our clinic, we've started doing social determinants of health screening. And I will tell you, we have more domestic violence recently. We have more houseless people. We have more people just struggling with really complicated problems. And we know like that's part of the ACEs piece, right? If we can address those needs. And we know NFP is evidence-based, it does its job, and I will tell you, it works, so.
Okay. Any questions for the members? Go ahead.
Just a comment on that note, I think I have seen real examples of where appropriate staffing lets you get ahead, right? If we're playing catch up all the time, whether it's with social determinants of health or supporting kids in our community or whatever, having just a few more people sometimes can make a difference in allowing you to do strategic planning and be proactive in any sort of operation, any sort of business. So I think a few positions in the right places could really help us.
I can-
questions, but could I ask a question?
Yeah, absolutely.
I think most of my questions were answered and I had my operations hat on. I was like, where's the funding? What do we do? And it sounds like that piece has been addressed because we did get funding. I'm assuming the funding to pay for these permanent positions, that these are permanent positions and that the funding is sustained, right? It's not grant or short-term funding, but it's intended to be.
Most of our funding technically these are grants, a lot of our funding is, but a lot of these are long-term grants from the state, if that makes sense.
Yes.
And for those that we know that are more short-term, I'm the kind of person who always wants contingency plans in place. And so we usually have multiple fund sources depending on what's happening. And so a lot of our staff, I wish you could see some of the spreadsheets that we have for some of our staff that are coded to anywhere from 2 to 6 different fund sources at any given moment to sort of make this work. One of the things that I will tell you that I'm excited about FPHS, for example, is it actually gets us out of that game a little bit where we're trying to track all of those different fund sources and we're cobbling $1,000 here and $10,000 there. This is funding that we know we're gonna get moving forward. And for a lot of our communicable disease programs, the state and the federal programs that are equivalent have been really clear that they're gonna move forward funding to support our outbreak control work as well beyond COVID. And so I feel very confident about our ability to get those done. And we're always gonna look for new grants and things like that, but the core, because this is core work, I wanted to find funding that was core funding and funding that I could feel good about these positions into.
I have one last thing.
Yeah.
So related to Commissioner Mejia's question, vacancy savings. This is an 18% FTE growth for the entire organization. It's big.
Yeah.
And I counted 28 new positions. I'm wondering if, because you're gonna have to stage bringing that many people on, some of the funding could be used for a temporary project recruiter or somebody in central services to help bring on almost 20% new staff.
Yeah, no, that's a really good, it's kind of the same thinking we had. I phoned a friend to make sure I got the right number. So right now, currently, we've got 138 employees at our, like today, right now. And yeah, so one of the requests at the very beginning that I noted in there was like an office assistant, which seems like a small request. But for us, it's a huge request when we look at the number of positions we're trying to manage. We're doing a lot of, I would say, sort of HR related functions, in addition to recruitment and our retention efforts, and so we're looking at really boosting that program to help us do that. It's been an area that we really struggled with traditionally because we haven't had sort of enough support, frankly, to do it. I feel really good about where this program is heading, and I think that office assistant is, I think, in my mind, kind of the final cog to that group of us being able to really kind of move forward to do our hiring and our recruitment in a way that is going to be quick and efficient. So
I do appreciate though that observation and the idea of bringing on a temporary HR specialist whose sole purpose would be to assist us in filling all of these positions. Because that's gonna be a big lift and we know we don't have capacity in the county HR office. So that's a good idea for us to
yeah,
think
I
about.
love it. Yep.
In my day job, I am the central services component of a large agency, and often we fund programs and big projects, and we don't fund the central services, and then we groan under the weight of the new obligations to fill those positions with existing central services staff. So don't want it to happen to you.
Thank you.
No, thank you.
When you said 138, is that filled positions right now or funded positions? Or are you completely filled?
That would include, those are filled positions. We've got, currently we've got, that includes some temporary employees too, which is the COVID employees. So that does not account for the vacancies.
Do you know how many vacant positions you have right now?
The number I've seen last, and I just got it confirmed, was we have about 20 vacancies right now. I think maybe 24, 25 vacancies. A lot of those, I'm looking at Gretchen, are struggling right now in a couple of areas, but I think a big area right now is on our nursing side. Most of those vacancies are pretty recent. I think I've done a good job of trying to fill those gaps quickly, but it's an area that we've really struggled with. And I will make a pitch here again. Part of the struggle with some of our nurses has been the fact that they are overworked. Like, just to be blunt, like we don't actually have a support structure that enables them to have any kind of a balanced work at this point. And that same thing applies to our division, which is the other area we see most of our vacancies. A lot of our kind of mid-level or kind of frontline staff, we've seen some high turnover there recently. And then a little bit on the disease control prevention side, but really and nurses, folks you're seeing out in the field are the ones where we see those vacancies. When I ran the report to look at vacancies, I wanted to see the length of time to see if we've just been sitting on vacancies for, years and months. And I'll tell you, most of the vacancies that we have there are fairly recent. I have very few vacancies that extend past this year, that we've just been sort of sitting on. We can't afford to sit on vacancies in public health.
Board Member Edwards, I thought I saw your hand.
Well, I'm just wondering if you've got 20-some vacancies now, and Robin, how many did you say new FTEs? So we're looking, about 30, 50. So we need to be hiring 50 people. And we heard from the sheriff today what that would be like trying to do it. So I would envision something pretty close to what he's talking about too. I mean, you might have to have a whole recruiting section
That's why.
as well
Yeah,
as that HR component of weeding them
Yeah, we're all
out.
on the same page about that. And I think,
It's not
And you-
it's
you-
not the same type of in-depth background checks
No,
that
but
the
it's
sheriff
still
needs, but there is a
substantial.
lift for recruiting, which is why I
And
so
you think this
appreciate
money
board
would
member
keep
fact-
coming in, you're pretty sure it's gonna keep coming. And it seems to have kept coming, up until this
It
point
has.
as well. So what is those upgrades, those FTE positions that you're not replacing, but you're upgrading, is that included in that 4.9 or 5 million?
some of it, yeah. There's a few of them that are currently funded by FPHS that we're using that money to also increase them. Some of them we're looking at other funds for that. And most of those reclasses, the cost for that reclass is pretty minimal. You're looking at a couple $1,000s for a lot of those reclasses. They're not, it's really about making sure we've got the people working in appropriate scope, right? And I will kind of make a plug there again, that I think we have asked a lot of our staff across the county, but I'm looking at public health. And I wanna make sure that we're doing it appropriately. So if I'm asking you to cover complex programs and managing lots of FTEs, I wanna make sure we're actually in a position I can do that. And not just say, oh, thanks for your service, we're gonna keep hoping for the best, or do things like temporary pay increases, which are just not, that's not sustainable for the county or for us, frankly. So that's kind of the thinking there too.
Then what goes along with that? A new facility, a added on facility? You know, I mean, you gotta think about the whole picture. If,
Capacity.
Yeah, so we've done a lot of work on this one of sort of mapping out, we've got basically two campuses for public health, as you guys know. We've got the Lilly building and then we've got space here in the atrium. We're looking at adding 2 people to the atrium in our EH office. The rest of the positions of the other sort of like 22 or 26 as positions, 9 of those are already here. These are the COVID team, it's already there. So now you're looking at 17 positions that we're trying to figure out where they'll go. Some of those positions are nurses. These are folks who are out in the field a lot. So they share offices. We've been really creative about having drop spots for folks. And so we're not asking the county to sort of give us a new facility or to expand beyond what we already have currently at this point.
but if we, kind of going back to what Robin said, maybe we will never catch up if we don't plan far enough ahead. So I don't know if you ought to be doing it on the cheap. If we're actually gonna go this route, why go, and I don't know if that's the right term or not. You know, why go on the cheap? Why not, if they're gonna pay for it, why not have them pay for what it's really gonna be for a period of time? I mean, this is gonna be ongoing. So
Yeah, and no, I think I really appreciate that perspective, and it's something that I have been thinking about myself and making sure as we work with our admin services team, especially, is helping me kind of plan about where the people will be and what is the real cost of an FTE, right? It's not just the person that come along with
Right.
stuff. We've built into the budget request involves, we're anticipating the cost of that person, right? So their equipment, their space, so we're not leaving that out, but I think you're right, Commissioner, as we're looking at the future, do we have space moving forward and what can pay for that? I think that's a good conversation. I say right now, I feel pretty comfortable about where we're at space-wise and the number of people we're asking for. I feel comfortable with where we're at between the atrium and Lilly. I feel comfortable right now.
You also may recall, Commissioner, that one of the items on your agenda, I think for next week, is funding or approval of a contract, because funding's in our budget, to do that long-range facility planning. And the capacity for where our staff are is part of that plan.
And I guess the other thing I think with these new positions, like with the epidemiologists and stuff, if we can use their expertise to really get an understanding of the county and then potentially use that to go get those grants and those other outside funding sources that like our Pierce County and King County colleagues do, I think we could really try to strive for like ongoing improved health, in a really good way by using data to fund, what we need.
I promise I didn't pay her to say that, but I feel like that is part of the request. You'll hear from me on Friday. I mean, this isn't just gap filling for today. It's also how do we set us up for success for the county. I think one of the things that I want to be so clear about, even though I'm the public health director, when I'm thinking about these positions, I'm thinking about the county, right? So when I think about our gap, it's not a gap for my office. It's a gap that the county has that I'm going, okay, how do we support the county in this gap? And how we do that, of course, is up for grabs and debate. But I wanted to be clear that when I think about this, I want to make sure we've got positions and people that are helping us to leverage funding that we already have well. And then to Dr. Harvey's point, if I have better capacity with assessment, I can actually better pursue grants that are specific to that. One of my sort of passions is prevention, and I will tell you that like we don't have a super robust prevention efforts here. We do what we have to do, and between the community wellness division and our disease control prevention, we do what we can. We're not where we need to be on that work. And to do that, I need to at least start with the EPIs who tell us where are the diseases, where is the problem, so.
Board Member Mejia.
Without going into the weeds, but I guess I'll give props to you, David, because it's really hard with getting this funding to not want to do all this new projects, but actually taking a step back and seeing like, actually I have to fill in these gaps, right? And so I want to give props to you for that, because I know while this is not, shiny, or it's something where it's going to be a continuation of the services that we're offering, and actually putting us in a point where it's stable, there's prevention added to that, and where we're not going to be in this cases where it's these massive backlogs where our staff are overburdened, really. So I just wanted to give you props for that, because I know, when this funding is coming through, I know there's probably a million other things that you're like wanting to do, but for you to kind of take a step back and being like, not now, but later, and now we have to fill the gaps.
I really appreciate that, and I'll be honest, like I struggled with that a little bit when you come in as a new director and you're thinking about like, how can you make a big splash and show that we've got all this stuff, and then I went, no, like we can't do that next level stuff until our like base level is actually okay. And so I think I appreciate you recognizing that, and I do think that this department is gonna be well set up for success in the future if we could have a good base. We're not going to be able to get there without the base being good. We just won't be able to.
Board Member Edwards.
You're putting, I don't know if it's, the Board of Health won't have to deal with it. We're talking about laying off 80 FTEs, or canceling them out and adding 50. So I don't know. I mean, that's gonna be a challenge. The sales portion of this will be quite interesting. if
Yeah, I
we pull this
don't
off.
envy your position on the board for those choices. I will tell you, if it sort of helps in your decision-making process, when you're looking at our funding, we are 88% funded by not the county. So when you look at our budget, if we were funded in a different way with general funds, then yeah, I mean, this would not happen, right? This conversation would not be happening at all. But because I'm funded so heavily from both the federal government and the state, and they're extending funding to me regardless of the county situation, I'm getting that funding. I feel like I would be irresponsible for not presenting with you a budget saying, okay, if we're gonna get this money, how should we spend it? And we look at our gaps for the county, it's not, our gap isn't we need to buy more computers. Our gap isn't we need to buy more swag for the department, it's people. I mean, that's where it is. And if the need was actually technology, I would present you a budget that is 50% technology, right? So I have funding that if we don't use this funding, so if you decide that, you know what, we don't want to repeat these positions, obviously you absolutely have that authority as the board, but I would tell you for the majority of those funds, I'm gonna have to turn those around back to the state and say, okay, we couldn't use that money. So it's a weird tension there. I will say that we also went through the same exercise as other departments to look at our 8% reduction. And we'll also be, if that's where the board decides to go, we have an 8% reduction ready to go on our end too. So we're not exempt from that process as well. It's just, we have a different fund source mechanism. And, most of my peers will grumble about the fact that their counties don't contribute as much to their department as they want to. I will tell you today, I'm going, all right, I'm actually grateful for the amount of funding we've got from other sources because it actually provides the county some flexibility to continue to move forward in a tough time right now. So Commissioner Edwards, I can appreciate the tension there of where you're at, but I will note that our department just isn't, it's just the way we're funded, it puts us in a different spot.
Oh, yeah.
So use it or lose that funding.
Oh,
but,
yeah,
yeah.
we recognize that. It's just, it's a
It's
balancing
tough, it's a
act.
tough call, I get it, I get it.
Okay, so sounds like we have a set of proposals. County commissioners will hear that later in the week. The Board of Health Subcommittee has heard it, and what I heard is pretty strong support for what's being proposed and some of the other comments. Appreciate that. Board Member Vasquez, you made some suggestions that I think we'll probably end up discussing. anything else? I mean, the Board of Health doesn't have to make any formal action at this point. We want to get all the input if there's any more to be had, and then I'll just move on to the next topic. Okay, very good, thank you. Then let's go on to Health Officer's Report. Dr. Abdulmalik is with us on Zoom. Good evening, Dr. Abdulmalik.
Good evening. I'm in Wenatchee at the Washington State Public Health Association conference, so coming in remote. But I did want to give a very brief update. So I'm gonna kind of start out talking about COVID. So we're at 2.8 hospitalizations per 100,000 over the past 7 days. So this is low. We're still in the low transmission threshold per CDC. There's been a big change in how the Washington State Department of Health reports out COVID data, as well as RSV data and influenza, so that we're seeing a positive change in that the new dashboard reflects all three diseases. However, it releases that information through accountable communities of health. So the data that I'm going to share, the data I'm going to share now is the Cascade Pacific Action Alliance data. So in terms of, this looks at ICD-10 codes. And so essentially these are diagnosis codes for ED visits and hospitalizations that are being tracked. So we're looking at 2.9% in terms of ED visits for COVID-19, and 2.3% of hospitalizations for COVID-19, and that's for the whole ACH. Influenza remains low at 0.2% of ED visits and 0.1% of hospitalizations, and we haven't had a significant uptick in RSV yet. We are watching our data carefully. Last season, we did see a significant upswing in viral respiratory transmission at the end of October, beginning of November. That was pretty sharp, and it stayed elevated through January, actually, pretty elevated. And there were several moments where our healthcare capacity was significantly strained due to burden from viral respiratory disease. So the good news is that we do have vaccines available. So COVID-19 vaccine available for folks 6 months and older. There have been some distribution challenges with commercialization. In calls that we've had with the CDC, there is a dose available for everyone that wants one. It's just a matter of getting the doses to the right places where people can get them. So, there's a little bit of a different distribution pathway with commercialization than there was during the emergency, where distribution was more centralized. I also want to encourage folks to get the influenza vaccine, which is available for 6 months and older, and for folks who are at risk for severe illness. So folks who are older than, who are 60 and older, folks who are pregnant, week 32 to 34 of pregnancy, to get vaccinated, and for parents to strongly consider getting nirsevimab, which is a long-acting monoclonal antibody for their, for infants 8 months and younger, and for children at high risk of severe disease in that 8 to 19 month age group as well. And with that, that's a lot of the high level stuff that we're working on and looking towards. And I'm happy to answer any questions. Thank you so much.
Any questions? Looks like we're going to let you off the hook easy, Dr. A. Thanks for joining us from Wenatchee. Okay, we're almost to the tail end. I know there's a few more announcements we want to make before we adjourn. I'll start with Director David Bain.
Yeah, I think we're gonna talk about the same thing maybe, and I definitely was looking at Assistant County Manager Rob Gilder as well. I think we announced at the last board meeting that we would be looking at our recruitment for the new members. And so There's been a lot of work, and I want to give a shout out to Rob and to Jen for really kind of bolstering this effort here. So one of the conversation pieces that you guys had at the board last time was whether or not you'd have the ability to create a subcommittee to review applications and sort of present some candidates for the full board. Our council has agreed. Jane thinks that that's something we can do, so that's great and it'd be helpful for you all. The chair knows that we've had a lot of back and forth about sort of the timing of this, and one of the ideas on the table is, should we call a special meeting? We've decided that I think we can pull this off in December if we have a longer meeting where you have both the interviews and the decision there. And Rob, I don't know if you want to kind of maybe talk a little bit about that format, what we're thinking there.
Sure, and I appreciate that. The idea was this meeting is already on your calendars. And with the subcommittee can only winnow down the candidates, but it cannot absolve the Board of Health from the actual interviewing process and selection. So if you already have the December meeting on, if we could then take the early part of the meeting, do the interviews, and then transition to a regular board meeting. Given that it is December, I think our initial review, there weren't a lot of large items. There would need to be an update to, I believe, the opioid response plan is scheduled for December. But beyond that, it would just sort of be the usual items. But instead of trying to pull you all together and get all the calendars to work out again, to have it all happen at once. Board Member Vasquez, I don't believe your city meetings have changed yet, not until next year? Okay.
They are changing though, right? I thought I heard you did approve starting in January.
Yes.
So at the December meeting, maybe we need to revisit
The
the topic of scheduling and just kind of reconfirm our approach on that to accommodate.
Right.
Lacey. Okay. Well, that was, yeah, I wanted to make sure that was covered. So basically the update is council said we can narrow the applications, but we can't actually do the final interviewing. The board must participate in the interviewing. So, and we've got 2 seats to fill, so it can't just be, it's probably gonna have to be,
Two,
I'm
maybe
guessing.
three.
Huh?
2, maybe 3.
Maria's position.
Right, so I mean, it's not just gonna be 2 or 3 interviews. It's gonna have to be 5 or 6 or 7 interviews. And we're gonna do, what was the proposal, 15, 20 minutes?
I think 15 per person
Yeah.
and narrow it down to probably about 4 questions that folks would have that would be, give the board an opportunity to go in a little bit further depth from some of the answers or questions they've
And we'll
already.
provide the written applications for the final
Correct.
pool that has been vetted by the subcommittee. And the subcommittee will meet, and Board Member Vasquez, Mejia, and myself will have to have a meeting where we review the applications and discuss which ones we'd like to promote to the full board.
And this would be done, and with support from the department is happy to help support. We're helping with the recruitment, getting the word out. We'd love to support the subcommittee with any questions they might have and facilitate your process going forward too. And again, just a lot of thanks to Rob for stepping in and helping us as we kind of plan this out.
And we're really hopeful you have a slew of candidates to actually go through. We're gonna keep our fingers crossed.
I had a question in regards to, so just a clarification, so understanding that the Board of Health has to be the deciding one, but you're saying that they also have to be the ones who do the interviews, so the Board of Health will be doing the interviews. What is going to be the format of that, and is it going to be a live stream, like what is? It's an open.
Correct. We are currently, we did get some feedback from the State Board of Health of the possibility that the deliberations could occur in a closed or executive session. But we need to reconfirm that with our own counsel, just to make sure everyone's on the same page. But the idea would be that in open session, regular format, streaming would be those interviews, 15 minutes per individual, same questions to everyone. and have that opportunity, hopefully then being able to recess into some type of closed session, do that deliberative process, come out, do the appointments, and then move on to regular business.
And providing questions in advance, that's correct.
Correct.
Isn't that how we did it last time
And then,
in 2022?
I don't think there were, it was.
We had them come to a meeting
Yeah.
and I had been
Live streaming,
appointed.
were
We weren't live stream.
Oh,
That's kind of,
that's the
it
new-
was still
the new
open to the,
piece.
and so that was my question, right? Because we had this discussion when we did the Timberland, like just live streaming, like is it,
That was another, to me, that was an additional, there are other arguments, but that was an additional argument for providing questions in advance. So no one's getting an advantage
Yes.
by not being first and sitting in here, because we couldn't stop them from sitting in and hearing the questions. And then you're disadvantaging the people that either don't do that or went first and didn't have an opportunity to do that. There's other arguments for that, you know, in terms of expanding people's comfort level and getting a broader representation of potential candidates. But that's one thing we're gonna do differently. But yeah, it's gonna be pretty similar to what we did before, I think.
As far as live streaming, I don't think we're required to live stream these meetings.
I don't think we should live stream that
They do
portion
need
of
to
it.
be open public meetings
Yes,
though,
anyone can
so,
walk in, but
Yeah, we're not required to live stream.
I mean, if that's the concern,
Personnel issue, so.
but they're open meetings, so people could definitely sit in.
I would, just for comfort level of someone interviewing, right? And knowing that these meetings are being live streamed, I'm just wondering how open of a response you get knowing, you know, some people tend.
you always imagine there's millions of people
Yeah.
listening.
I wouldn't want someone to kind of clam up just,
Sure.
I know that, well, once they're on the board, right, you have that. But just in an interview, knowing that you're already nervous interviewing and then just having that additional aspect of it, I think adds another hurdle. So I'm in agreement with instruments, or maybe not live streaming that section of the meeting.
We can work with those logistics.
Sure.
Board Member Vasquez.
Do we know yet what the close period is for the open recruitment?
So the recruitment has gone on the street this week, and our close date hopefully is the 22nd of November.
Just
And
thinking about the need for the subcommittee to gather once we have all the
Right,
applications.
so we would have probably a couple of weeks in which to convene the subcommittee. Would love to get it on the calendars, obviously way in advance.
Tell your family that you won't be there for Thanksgiving. We'll be vetting applications.
Actually, for part of that
All right,
time,
I'm
so
just
I'll
kidding.
come back just
We'll
for this.
figure out the time. But hopefully it will be a burdensome process because we're gonna have a stack of awesome applicants that we've got to,
The problem you wanna have.
yeah, it's a problem that I would like to have.
Yeah, and can you just share with us the recruitment info and like what the buckets of people you're trying to fill, just because I have some people that might.
Definitely, we will make sure that the entire board gets that. So if you know of individuals, you are our best recruiters, right? Word of mouth is probably still the best tool we have, even in this day of social media.
I would say, to the specific question about what we need, we know that we're missing, one category for sure, which would be the, health consumer category for the Board of Health. So we can double fill other positions as well, but just, we know that no matter what we do in
We
that,
have to have one of
we've
those.
got at least one of those, members has to be filling the health consumer, piece, which is more of a lived experience, piece.
And thank you for that. So the Board of County Commissioners will be scheduling a hearing to actually amend the ordinance that governs the structure of the Board of Health. And at that, we'll have the flexibility, because it's 3 buckets per the WAC, and with RCW and the WAC, but we'll have 5 people. We know that we'll have at least 1 in each of those categories, but potentially 2. Or 3 in the one case scenario.
Oh no, you've gotta distribute them, so.
Well, we could definitely have to have 1 per,
Right.
but you could get two.
Right.
That's, so you have 3 in 1, but
Yeah, it
That's
depends on
math
how
we
the
can worry about
applications
later,
shake
yeah.
out too, yeah.
Anything else? Good, go to the order?
Go to the order.
Yeah.
David, thank you. This was really put together. I mean, I know you had folks helping you, but you made it pretty easy to understand where you're going and what you need, so.
Thank you, I had a lot of help,
I know, it takes a whole team.
Somehow the boxes and the colors was a lot better than like the spreadsheet that, you
Yes,
know.
yes, it was. For
Which is
me,
what we
it's
usually get, and it just,
graphic and
you can't sort of comprehend it, a
Yeah,
20-page
my-
spreadsheet.
I kinda
My
need
poor
visual
brain needs
sometimes, I
colors and
think.
shapes, so this is, that's how I work.
We're like preschoolers, colors and shapes, right?
Listen, it works for them.
All right,
Thank you.
all right, everybody, we are adjourned, thank you.
Thank you.